Good afternoon, everyone, and thank you for staying here till the bitter end, which has been a phenomenal meeting so far. Thank you to the organizers and to the scientific committee for giving me the opportunity to present. And you know, this is a very this is a big topic, obviously, so I'm going to give it maybe just a little bit of a different twist, but a really very important one. Here are some of my disclosures, which really are mostly educational in background, and they do not have any bearing on the talk. But really, probably my biggest disclosure is I really enjoy coming here. I enjoy seeing colleagues, and it's just we've been doing this for a few years now, and really the level of scholarly work, of scientific exchange is just absolutely phenomenal. And as somebody who you know knows a little bit also about the region from an outsider, I always tell people this is definitely the leading spine society in this entire region. So congratulations to everyone who's part of it. Focusing on the disease process, this should be pretty quick and to the point. Almost everybody likes the cervical spine, right? Why do we like the cervical spine? Because it's mostly surgical. Right? The back, maybe you can say 40, 50, 60% of back pathology is surgical. 90% plus of cervical spine is surgical because they come to you with myelopathy, radiculopathy, and it's surgical. So all of us like the cervical spine. When we look at the anterior approach, we like the anterior approach, right? Everybody likes, who doesn't like an ACDF, right? Muscle sparing, quicker recovery, less post-operative pain, but you have real consequences like hematoma, dysphasia, esophageal injury. The posterior approach, of which admittedly I'm a big fan. I really like posterior cervicals, and I'll go into detail why. No visceral or vascular injuries. I mean, you really have to go out of your way to injure the vertebral artery, especially in the subaxial spine. There's no esophagus to worry about. There is no recurrent laryngeal nerve. But there's definitely post-op neck pain. Neck pain, and the correction that you achieve is probably not as good as the anterior approach. Now, we can, you know, I mean, I can spend 20 minutes just talking about the literature, but the bottom line is dysphagia after ACDF surgery is real, but it's so variable, right? How many times have you done a 2 or 3 level, or maybe even a 4 level ACDF, and you said, wow, this patient is definitely going to be upset, and they're fine. And sometimes you do a 1 level, and the patient wakes up and has dysphagia, and it's there for days and weeks, and it's just very difficult to predict. And people say, well, you have to take some air out of the endotracheal tube cuff. Others say you have to reposition the retractors, but the truth is we really don't know. It probably has to do with multiple factors, but dysphagia is very real, and my approach is very basic. I tell my patients it's going to happen. It may not, but I'm going to tell them it's going to happen. Be prepared for it. You know, thank God we never had somebody that needed a tube or had permanent severe dysphagia. But counsel your patient. Tell your patient you will have dysphagia. Number 2, and this is maybe a little bit controversial, and it depends on the region. I don't know what the common practice here in the kingdom is, but in many places in the United States, especially in larger centers, complex revision anterior cervical, infections, abscess, post-radiation, we very routinely ask ENT surgeons to basically co-surgerize with us. They do things a little bit differently. They have bigger exposure. Sometimes they do the exposure and you say, wow, I would not have done that, because they usually like to do a neck exploration. But it really takes a little bit of pressure off the operating spine surgeon, number 1. But the most important reason is any post-op neck issue, dysphagia issue, you can send them to your ENT colleague. So we're very quickly to use ENT for these cases. And dysphonia. Dysphonia is something not to be taken lightly. You know, this is actually a question you have to ask patients, you know, especially in the US. Do you sing? Are you a professional singer? Are you an amateur singer? Because if you don't ask, they may not tell you, and they will notice minor changes in the tune and the pitch of their voice, and that could be a serious thing, and they're going to be upset. So always, you know, I always ask patients if they, you know, if they're part of a choir, they're part of a you know, amateur group, If they're singers, I don't do ACDFs there. So there's a lot of great reasons to do ACDFs, but also there's some not great reasons. So I'm just going to give you, my personal thoughts. This is my personal thoughts on ACDF surgery. Number one, I do reposition the retractor for each level. So if I'm doing a 3-level or 4-level or even a 2-level, I don't keep a top-down medial lateral retractor for the whole 2 hours or 3 hours. It takes a little bit more time, but I do think that decreases the amount of pressure on the esophagus and the recurrent laryngeal nerve. I think like a lot of you know here, we used to do a lot of PEEK, we used to do a lot of allograft, maybe some still do structural allograft. I've migrated to primarily all titanium implants, including inner body and the plating. I don't use BMP in the cervical spine, not in the anterior. I use self-drilling variable screws. I don't know what folks here like, but I've had very, very good success with them. And this one is probably the most controversial, and the neurosurgeons in the audience are not going to be happy with this, but I don't always open the PLL, actually. Unless it's a subligamentous herniation, often I will not. If it's just a disc bulge, I'm very, very okay with relying on a little bit of indirect decompression and bringing that ligament back. And the only reason I can say that is because I've studied my own patients, and I know that the outcome is very effective. Standalone, I have mixed feelings about it. I feel like I'll do 10 or maybe 15 or 20 standalones in a row, and then I'll stop and go back to a plate. I haven't made up my mind on standalones, but I do like them for adjacent segment disease. And for some of you that we've talked for a long time now, everybody knows I really like arthroplasty. I like cervical arthroplasty for the right patient, and I'm a big believer in it. So that's the ACDF. I think it's very successful, has great outcomes. But how about the posterior cervicals? I actually like posterior cervicals a lot more. And I joke around with this first line, but I really do think it's true. There's nothing a C2 to a T2 can't take care of, whether it's infection, tumor, multi-level severe cervical stenosis, you name it. If you close your eyes and say, what's the solution? C2 to T2 will usually take care of it. Now, I'm not proposing you do that on everybody, but I'm saying the posterior cervical is a very robust procedure. You never have to worry about dysphasia. Never have to worry about dysphagia with posterior cervical, unless, of course, you're going to the occiput and you fuse them in flexion, but that's a different surgery altogether. Post-operative neck pain. A lot of people say, oh, if you do a big posterior cervicals, the patient's going to have neck pain. I think that's both true and not always true at the same time. Big muscular guys or big muscular men, yes, they will have a lot of neck pain. Your older ladies, the ones with very, the muscles, maybe the muscle bulk is not too strong, they actually don't. You see them at 2 or 3 weeks, they say, oh no, I'm fine, I just have some incisional pain. So I don't think the post-op neck pain issue is really all that common. You do need to go anterior if you're doing a deformity correction. And the last one here, I don't know if anybody still does laminectomies alone. I like laminectomies, posterior cervical laminectomy. I have no problem with it. I see here Dr. Akkad agrees. Listen, 95% of the time, I'm like everybody. I do like to put instrumentation. But for my for my octogenarian patients, I have no problem doing a quick 2 or 3 or 4 level LAMI and calling it a day. And I actually have not regretted doing that. And a lot of you have seen these pictures before because I do post a lot of my cases. So on the bottom right here, for those of you who haven't, that is a 1-year follow-up MRI on a posterior cervical, C3 to I believe it was C3 to C7 laminectomy and fusion. And I was looking for adjacent segment disease, but you could see that even the anterior pathology resorbs or regresses with a posterior cervical approach. This is all posterior, and you can see the anterior disc bulges actually even regress. So I think posterior cervical doesn't really get enough credit. Now, obviously, if you're dealing with a terrible deformity, then you have no option. You have to go front back or back front or sometimes both. The top left is a case of mine now, 3 years old, post-radiation kyphosis, post-radiation rigid kyphosis where we went front and back. The bottom left is a metastatic disease with kyphotic deformity, and then the one next to it is a rheumatoid arthritis deformity. So sometimes you do have to employ both anterior and posterior, but again, getting back to the posterior, this is a young lady with a drop head syndrome. It's actually one of the diseases that I spend a lot of time studying, and we decided to go all posterior with some really good PCOs, some good osteotomies. You can get really good correction, and we did not need to go and do a multi-level anterior. She's 2 years out right now. Our own humble contribution to the cervical literature, again, these are some of these are a little bit older, but resecting the PLL is not always necessary. We've looked both at a literature review as well as our own patient series. You do have to, if you go posterior, you do have to go long sometimes, especially if it's a high T1 slope. If somebody's coming in with a high T1 slope, stopping at T1 or T2 is a disaster. You really have to go lower that, T4 and sometimes even lower. The anterior obviously is going to get you the lordosis, and then for the very high cervical or very low cervical thoracic, there's some special clinical anatomy there that's really important, and I think it's definitely important to review that. So thank you very much for listening to this talk. This is our wonderful team back home in Arizona who I absolutely adore, and they're really behind a lot of this work. And thank you very much for having me.